Morning. I'm just gonna get going straight away, I think. Looks like everything's good. Hi, Steph. Happy Monday. Right. Yes, I want to crack on because I want to get to sciatica today. So this is a little bit of a recap of the kind of beginning of um, spinal tracts, and then we'll go into them in a little bit more detail. And then I showed a video, I think it was last week, about something called clonus. So we'll go over that again and why that happens, just to make sure everyone is good with that. I had a feeling it might be you, Becky. Good morning. Right, let's get going. Yeah, so this stuff we've had a look at before. And it was the cross section of the spinal cord. So if you have the spinal cord length and then you cut across it, look top down, then this is what you'll see. And there's a butterfly shape in the middle. Let me just grab my arrow there. So this butterfly shape in the middle, and then the surrounding cells all around here. So we've got different sections. So we've got grey and white matter. So the grey matter is, and if we think back to what we did last week and the week before, I think as well, we were talking about interneurons. So where a sensory neuron comes into the spinal cord, and then there's a synapse with an interneuron, so a connecting neuron, and then going straight to the motor neuron. And the reason why this area is grey is because of the density of neurons. So there's lots of interneuron activity in this butterfly area. Okay, so that's why we've got that change in colour. So yeah, we've got it's divided into horns. So we've got an anterior grey horn, lateral grey horn where there's a little bit of a projection here, and then a posterior grey horn just there. And the horns connect to the nerve roots. Okay, so let me just go back to that. Let me just show you this. Spinal nerve roots. They are. Okay, let's have a look at this. So I'm just going to connect those two together. So here we are. Just pop that there. So these are the nerve roots coming out here, and you've got some coming out of the back and some coming out of the front. The ones coming out of the back are the dorsal roots, and they are sensory. The ones coming out of the front are ventral roots, and they are motor. Okay, so if you imagine this spinal cord here being cut here, and then you're looking top down on it, you'll be able to see the butterfly shape, and the nerve roots at the back will correspond with the posterior horn, and then the nerve roots at the front will correspond with the anterior horn. So let me just show you this video, and then I'll go back to that picture and explain it again. So you can see the kind of these little rootlets coming out here, and then there's the main spinal root, spinal nerve root just there. And I'll explain that in a bit more detail in a sec as well. So you've got the joints here, the facet joints, the little faces, and then there we are. Okay, so this is a really nice one. So we've got dorsal and ventral roots coming out, and then the connective tissue that surrounds it is the dura, and then that's all connected into the nerves as well as they emerge from that space. And then we've got the dorsal root ganglion, which is a bunch of sensory nerves, so kind of like a collection, a bigger collection of sensory nerves. And then that's a mixed nerve coming out there. So you've got both motor and sensory just there. Different branches. So we've got a front branch and a back branch. The front branch will go to the front of your body, the side of the body. The back branch will go to and supply the skin and the muscles on the back. So immediately coming out the back. So we're jumping straight into it this week. I've got a lot to cover. So the rami is a branch, so that's your anterior rami, and that's your posterior rami just there. Okay, So let's do that with this. So this bit here, the anterior grey horn, there will be little nerve rootlet projections coming off of here, and then they will then form the nerve roots coming out the front. Okay, and then you'll also have neurons coming out here, and then that will form the nerve roots coming out the back. So if you can imagine this, that top-down view with the nerve roots coming out here and here, yeah, so on the outside of the spinal cord. So the posterior horn contains interneurons and sensory neurons and relates to the dorsal roots. So the posterior grey horn just here connects with that dorsal root, okay, and comes out that way. And then the anterior grey horn contains motor neurons, relates to the ventral roots, so the ones coming out the front. Okay, just make sure I've not missed anything. Welcome back, Tris. I hope your holiday was good. Careful in that there, London. Good, Carol. Good to see you in this morning. Right. So yeah, and then the lateral horn. We'll talk about that. That's a whole couple of episodes on its own. Contains autonomic neurons and are only found in the thoracic and upper lumbar regions. So you've got this area, this sympathetic chain that goes up and down the thoracic spine. We'll talk about that on another day. Okay, so posterior grey horn, that's the sensory section. Anterior grey horn, that's the motor section just there. Okay, so that's how that all relates. And then the white matter, and this is important for the tracts when we come to that in a second. So we're going to do the tracts and then we'll come back to the reflexes, and hopefully it will make a bit more sense then. So the white matter around the butterfly, so all these cells around here, divided into regions called columns, and the columns extend up and down the spinal cord. So we have an anterior column, a posterior column, and a lateral column, and then there's further divisions of those as well. So we'll have a look at those now. Let me just grab that PowerPoint. Here we go. Okay, so the columns that go up and down in the white matter, they have different functions. Okay, so we have some that are sending information up to the brain, and some that are receiving information from the brain and telling your body what to do. Some of it is automatic, some of it is voluntary, a bit of a mix, and it's all happening simultaneously. So we were talking about this with a reflex. So when you get the basic teaching of a reflex is you step on something sharp or you touch something hot. That activates a sensory neuron, which then synapses with an interneuron, goes to a motor neuron, and then activates the muscles that pulls your hand away or your foot away, whatever it is. And when I first started learning it, that was all that I thought it was. But there's also a message that goes up to the brain at the same time, which obviously makes sense, to let your brain know what's going on. So it's not just the reflex arc, there's also information going to the brain as well to let your brain know what's happening. And that they, depending on the sensation, will depend on the tract that is used for that information to go up to the brain. Okay, and then the information coming back down again via the motor neurons will, depending on if there's something wrong with that person, they may have an adverse reaction to that information. Okay, so but sometimes with certain conditions to do with the brain and the spinal cord, the transmission of the signals gets messed up. Okay, and you have these weird things that go on. So something that we looked at last time was something called clonus, and we'll have a look at that again and what that all means. So we haven't covered this bit yet, so this is new. So the spinal cord has two principal functions in maintaining homeostasis. So we've got nerve impulse propagation, and then integration of information. Just get rid of that so we can see everything. So this is what we've just seen on the previous slide. So we've got the grey matter and the white matter. The sensory input travels along tracks towards the brain. Okay, so when you receive information via those dorsal roots, depending on the information, it will then access a certain tract. So if you imagine it like a kind of lift, like an elevator. Okay, so you've got all these different elevators in the spine, and depending on what information is coming in, the information will go into a certain elevator and then go up to the brain. So one will be for touching something sharp, and then it will go into a specific elevator which carries the sharp information. Another one will be light touch. So if you touch someone with a feather or a piece of cotton or something like that, then that will go into a different elevator and then go up to the spine, up to the brain. So we've got all these different elevators receiving different information. And that's really important when we're doing neurological testing, because when we do a neuro exam, we test all of those different sensations. And what we're doing is we're testing those tracts to see whether the information is being received. Okay, so then we've got motor impulses which travel down from the brain towards the muscles or organs. So it will be to move something or to release hormones or whatever it is. Okay, so secrete enzymes or whatever. The names of the tracks tell you which direction they go in. Okay, so if we have a look at this, this is one of the tracks. I'll explain what they all do. Some of them are more important for musculoskeletal clinicians or people who work with MSK than some of the others. And if you go into like neurophysio, then you'll go into this in a lot more detail. So the anterior corticospinal tract. Okay, so that's one of the tracts. Anterior means it's at the front. Cortico means it comes from the cerebral cortex, and then spinal to the spine. Okay, so what that breaks down into is at the front, from the brain to the spine. So if it's going from the brain to the spine, then it must be motor. Okay, so that's why they've got all these weird and wonderful names. But when you break it down like that, it tells you the direction in which they flow. Okay, so what the brain and the spinal cord is trying to do all the time is to create a homeostasis. So it's trying to create a balance. So we've got sensory input coming in, and then we'll have a response to those sensations via the motor output. Okay, so that's what the nervous system is trying to do. It's trying to create that balance. So why have I got Dave? This is a way. Sometimes you'll hear people say afferent and efferent. Sometimes it will be sensory and motor, and they mean exactly the same thing. And it's one of those things in anatomy where you just have to learn it. So the way to remember it is something called same Dave. Okay, so we've got two Daves, they're the same. So sensory is afferent. Okay, so they both mean the same thing. So if someone is talking about afferent information, then that is sensory information arriving into the body. And then motor is efferent. Okay, so if we're talking about efferent sort of signals, if you like, then those are motor nerve impulses. So sensory is afferent, it's exactly the same, they mean the same thing, and motor is efferent. So if you hear efferent or afferent, if you just remember same, then you can work out which is which. And then where do they come from? So dorsal is afferent, ventral is efferent. Okay, so the back of the spinal cord, so those posterior or dorsal roots are is where the afferent information comes in, and then the ventral roots is where the efferent information goes out. Okay, so sensory afferent, motor efferent, that's your same, and then dorsal afferent, ventral efferent, that's your Dave. Okay, so if you're in an exam and they talking about that information, or you're reading a report or something like that, then if you remember two David Beckhams, then you won't forget it. Okay, right. Okay, so hopefully now, with all that information we've just been talking about, this picture will make a bit more sense, because this is one that will, when you first look at it, go, oh my God, what the hell is going on? So if we have a look at the color coding, first of all, we've got blue, which is sensory, red, that is motor. So sensory is ascending, so that's the lifts, the elevators that are going up to the brain. And if you have a look, we've got different lifts. Okay, so in the posterior column, remember there were those regions, the tracts going up. So in the posterior column, it's split into two. Okay, so there are two lifts. In this kind of lateral column area, we've got posterior spinocerebral tract. So we've got one lift going up there. Anterior spinocerebellar tract, sorry, that one going up there. The reason why I don't know the pronunciation of those very well is because we don't really cover those in MSK, not for basic neurological testing. So we're mainly focused on this one here, posterior column, and the spinothalamic tract. Okay, and remember we were talking about the wording. So if we have a look at spinothalamic, have a think about what that might mean, and we've got spino to do with the spine, and thalamic to do with the thalamus. So which direction is it going from? It's going from the spine to the thalamus, so it must be sensory, okay, because it's going up. All right, so hopefully the information from before will make this make a bit more sense. So yeah, in MSK we're interested in this spinothalamic tract and the posterior column. Okay, those are really important to us. And as you can see, the blue arrows are going up. So these are lifts that are taking the information in. And if we have a look, this is the back, okay, because there's the dorsal root ganglion, which is that collection of dorsal sensory nerves, and it's coming in the back here. Okay, so this is where you're receiving information, and then this is the motor section coming out that way. Okay, so that's where motor neurons will go. Now, what this image doesn't show you is that this is obviously repeated on the left side of the picture as well. So we've got a posterior column on this side, and we've got a spinothalamic tract on this side as well. But just to make it easier to understand, they've taken that information off. Okay, so that you can see what one side goes down, one side goes up, but in reality, you've got up and down on both sides. Okay, then the one we're interested in on the receiving information, so the motor tracts, is this lateral corticospinal tract. Okay, so that's the one we're mainly interested in with the kind of stuff that we would be looking at. So the important tracts for neurological testing are the spinothalamic tract and posterior column. Okay, so those are our main ones. And for sensory testing and motor wise, we're looking at this lateral corticospinal tract. Okay, so hopefully that makes that picture make a bit more sense now. Okay, so information is coming in here, and then depending on what the information is, it will choose which elevator it goes up in. Okay, now which elevator is which? These are they. So we've got light touch, so touching with a piece of cotton wool, or I use take it out of my kit, I use a makeup brush, okay, for light touch, and that information travels up the anterior spinothalamic tract. So spinothalamic tract is here, so light touch will travel up this elevator. Okay, so it will be received from the body through this sensory nerve root, which is the dorsal one. Okay, and if you remember, same Dave, dorsal is afferent. So this is afferent information coming in, getting in that elevator and going up to the brain, the thalamus, and then the brain then deciding what to do with that information. Okay, sharp touch which like pinpricks, that kind of thing, is your lateral spinothalamic tract. So there'll be a section of the spinothalamic tract that's more lateral, and that will be specific sharp touch and also temperature. Okay, so if you feel something hot or something super, super cold, then that will activate thermoreceptors in the skin, which will send information via your dorsal root in here, and then that will go up your lateral spinothalamic tract and tell your brain what's going on. So when you're doing neurological testing, sometimes the light touch will be okay, but the sharp touch might be quite dull. And then that maybe will affect the temperature as well. So, I mean, we can't diagnose just by doing their tests because they're not very specific. There is something going on with their nervous system. Okay, so if we think about if we're doing a test like that, the points at which there could be a problem could be you're not pressing hard enough, okay, to stimulate those receptors, or light enough, you're pressing too hard maybe. They may have a loss of sensation in the skin in that area, so they don't feel it. Okay, so it's a skin problem. Or it's somewhere along the pathway of that nerve, there is a compression of that nerve, so the information isn't getting into the spinal cord. Or there's a problem at the cord, or the elevator's broken. Okay, so there are so many points along that pathway where there could be a problem, then it is beyond us just using a bit of cotton wool to see if someone's got light touch to say you have a problem with your anterior spinothalamic tract. Yeah, we can't say that. We just know that there are abnormal findings on neurological testing. Okay, and then they would need to be sent away for further investigation. There are all sorts of things that will affect your light touch, and especially this one as well, vibration sense and proprioception. So vibration sense proprioception is the posterior column, so it's this area here, and that is one of the first senses that you lose if you suffer with diabetes. So that could be a problem with the posterior column, but it may also be nerve damage, especially in the toes and the hands at the site of where you're testing. So again, we don't know whether it's coming from the cord or the elevators going up to the brain, or whether it's local. We just know that there's a problem. Okay. So these are the elevators, if you like, that we're interested in when we're doing sensory testing for a neurological exam. I hope that makes sense if you've done those kind of things before. So on the motor side, and again, obviously we've got the sensory pathways going up. They've just been omitted from this side of the picture. Remember, we were mainly interested in this laterocorticospinal tract, and that is because this controls the voluntary movement of limbs. So when we're doing myotone testing, so if we're testing muscle strength, then that's what we're analysing. But again, if we think about the pathway of what is happening, could it be that when you push to try and resist against a movement, there's a problem with the tendon? Maybe there's a problem with the muscle. Maybe there's pain in the area and that muscle is being inhibited, so it can't contract fully because the body's not allowing it to. It may be completely torn, or it may be that it's not receiving its signal. Or it could be that because when it receives its signal, there's an exchange happens at the muscle of neurotransmitters, and it may be the neurotransmitters that aren't working and not getting to the muscle. So there's so many different things, again, that could be causing that muscle to test weak. It's not necessarily just this tract. Okay, there could be a number of other things. And again, obviously with a good case history, we try and find out what potentially it could be. But again, they need to be tested. Okay, so if you're picking up anomalies on a neurological exam, then we just refer. Okay, we need to refer them out. Then we got, anterior corticospinal controls the trunk and axial muscles, and then corticobulbar controls the motor function of the face, head, and neck. Okay, so we've got different pathways again, but this time for motor. Okay, so the information is coming down in different elevators depending on what region of the body that it's going to. Okay, cool. I think. Oh no, oh yeah, sorry, I was thinking that looks exactly the same. So this is the autonomic pathways. These are the autonomic pathways. Again, don't really cover these on MSK, but they are there for you for your interest. And if you've got kind of autonomic function where there is a problem, you would ask questions about that on a neuro exam. So for example, let's have a look. Controls head movements using visual and auditory input. So that would be more of a cranial nerve exam. Okay, we did a whole section on cranial nerves. I think it took about 3 months to go through those. We've got the reticulospinal tract, preparatory and movement related activities, postural control, modulation of some sensory and autonomic functions, and then this one, the medial reticulospinal, responsible primarily for locomotion and postural control. So if you're having issues with these, is starting to look a bit like a stroke or something like Parkinson's. So we're looking at it going, something just isn't right. They need to be sent off for further investigation if obviously they've not already been assessed. Okay, cool. Hope that all makes sense. So that is spinal tracts. And then if we go back to this, so if we go back to this one, so when you're doing a reflex test, you hit the tendon gets really quickly stretched. Okay, that's what the tendon thinks has happened. The tendon then thinks, so for example with the knee, it thinks that your leg is being bent back really, really quickly. So to preserve the muscle tissue, what it does is it gets you to contract your quads to protect the muscles so that they don't get overstretched and then injured. Okay, so that's the purpose of a reflex. So quick stretch on the tendon, it thinks that the muscle is going to be ripped, so it contracts the muscle to protect it. Okay, so if we think about what's happening there on a neurological level, so we've got that quick stretch, that sensory information is going to the spinal cord, and then in the spinal cord there'll be an interneuron that goes to the motor neuron that activates the quads, and then the quads will contract. Okay, so that's what's happening. Remember that loop that we looked at previously. But remember, at the same time, a bit of information, the sensory information, has hopped on an elevator up to the brain to let your brain know that something has just happened in the quads. And in a normal reflex action, the brain will then go, oh, it's okay, we'll turn the quads off so that they don't stay contracted. Okay, so we'll relax them. This is what happens when it goes wrong. Okay, so this guy has come in. Again, we talked about this, I think it was a couple of weeks ago, it might have been last week. This guy had a problem with his neck. Okay, so cervical spine. He's got progressive leg weakness, so that's one of the reasons he's been referred to this guy. And so this guy is doing a neurological exam, and obviously he's got his history as well, so he knows that he's had this neck problem before, which affected the cord, spinal cord. There we go. So surgery on the cervical spine for stenosis, a C5, C6 fusion. So a stenosis is just basically like a narrowing of that region at C5, C6. So if that's the case, then it's going to affect a lot of nerves, okay, because it's so high up. So if we have a look at his reflexes, so because there's a problem with the lowers, we test the uppers first. So test triceps, C7, biceps and brachioradialis. testing C5, C6, and then compare it against the other side. And this guy's pretty jumpy. I think I mentioned this last time. Yeah, his reflexes are quite brisk. And then the affected leg is the right one. Yeah, so that is hyper-reflexive there, big time. That's a big knee jerk. And then this is the one where there's the problem. And we get this clonus, which is a constant contraction and relaxation. And it's because the brain can't modulate the information, okay? Because normally that would happen via the tracts, but there is something going on with those tracts that is affecting it. And because of the increase in reflexes, that is likely to be an upper motor neuron issue, okay? So something to do with either the brain or the spinal cord, which causes your reflexes to go through the roof. Yeah, if you notice something like that on reflex testing, then you would need to send them to get analysed by a specialist. Okay, so someone like this guy. So if it was, so I talked about upper motor neuron lesions, and that's what happens. Everything goes up. Yeah, so the reflexes go up and you get clonus. If it's a lower motor neuron, then that's the bit that comes outside of the spinal cord and everything is down. So when you test the reflexes, they're really dull, okay, and or maybe absent. And so, for example, I tested someone who had a foot drop and that didn't really have sensation down the leg, like pain, but just had a loss of function. And I tested their reflexes, and they were absent. So I sent her off to go and get checked out. I did advise her to go to A&E. And she got immediately seen, and they operated on her that day. She had a disc bulge that was encroaching on one of her nerves, and they immediately operated so that she could hopefully get her function back. Because the longer you leave it, the more likely it is that you're going to have a nerve damage, and it will be permanent. Okay, so. And because the reflexes were absent, it was more likely to be a lower motor neuron problem, so outside of the spinal cord, and in this case, it was a prolapse that was squashing the nerve. Okay, so she couldn't. I was hitting a tendon, but the information wasn't being received by the spinal cord, so there's no reflex. Okay, so that's why that happens. Cool, right. Hopefully that all makes sense. Excuse me. Right, let's have a look at this. Here we go. So I'm going to start sciatica. Sciatica is quite a chunky project as well. So this might take us a couple of sessions. Yeah, just want to go over some of the misconceptions really, and the things that people say. You hear it all the time online. You hear patients saying it, even hear medical professionals saying things incorrectly as well, which then makes people Google stuff, and then it causes all sorts of problems. So I think Carol posted a link to a guy called Tom Jessen. He's like the sciatica expert. He's made it his life's work basically to explain what sciatica is and help clinicians understand it. So, and a lot of the information I've taken from this is from Tom. Okay, so I'd highly recommend getting his book. Well, he's got a few books out and a few zines and stuff as well. So he's done loads of like fancy pictures and things, which is good. So, one of the key things is that everybody, if you've got pain down the back of the leg, it gets called sciatica. And it's a bit of a lazy diagnosis, because sciatica just means pain down the back of the leg. So what we need to understand, is it radicular symptoms? Is it a radiculopathy, or is it referred? Okay, and we don't know until we do the testing of it and listen to the case history to see what's going on. So with referred pain, there are two main types of referral. you can have visceral referral. So this is from the organs. So if you have inflammation of your liver, if you have a problem with your spleen, any one of those organs, then it can irritate the structures around it, which are highly sensory innervated, and then stimulate a response from those sensory neurons. Okay. We've also got somatic referral, and this can be from bones, from cartilage, from muscles, but not nerves. Okay, so if there's a problem with, say, for example, a joint, there are specific patterns of joint referred pain, and they're called sclerotomes. Okay, so you may not have heard of that before. Let me just write that down. And these are widely reported, so that's how it's spelled. So if you want to Google it, then you can. But basically, this is really common. So you can have irritation of the sacroiliac joint, and you do all the tests on it, and it tests fine. So all the movement analysis, it's all good. But for some reason, there's some kind of chemical irritation in the joint, which is obviously being picked up by the nociceptors in the body in that region, and you get referred pain, usually down the leg a little bit, but mainly into the glute, and it looks like a gluteal tendinopathy or a high hamstring tendinopathy, that kind of thing. So you treat the tendinopathy and you target it with shockwave and exercise or whatever it is that you do, and it just doesn't get any better. And it's because it's not coming from there, it's coming from the joint. Okay, and if you have a look at sclerotomal patterns, then you will see common patterns of joint related pain. The neck is a classic. So you can have neck facet joint irritation that looks like a trapezius problem. So if you're a massage therapist, then the majority of the time you do, obviously you learn about the neck, but you don't learn about sclerotomes. So you think there's a problem with someone's trapezius, so you massage it, and then it doesn't get any better. So there must be something else going on, and that's where you'd refer for someone to have a look at their neck. Okay, so it's usually dull and diffuse. It's that kind of dull ache, dull pain, and yeah, it's not specific, it's spread, and which is very similar to tendinopathic symptoms as well. So they look very, very similar. Why do we get it? Well, we get it because of this. So this is a classic one. Just get rid of that. So with the visceral referral, and I've talked about this with musculoskeletal referrals as well, underneath your diaphragm are your organs, so your liver, your spleen is quite close as well. You've got the stomach just poking up around here too. So let's say you've got a problem with your liver. Okay, so the liver has become infected. You're not feeling very well, but it's in the early stages of it. So you're not completely yellow. You haven't gone jaundice yet. Okay, so you go to the physio. You go to the doctor, and you say, "Doc, I'm feeling a bit under the weather, but other than that, I've got a really raging pain in my shoulder." So they send you off to the physio to get exercises for your shoulder. And actually, there is nothing wrong with your shoulder at all. It's a problem with your liver that has irritated the sensory nerves of your diaphragm. Okay, so if we have a look here, the phrenic nerve is C3, 4, and 5. So the nerve that innervates your diaphragm comes from your neck. Okay, and basically as you grow, as you develop, those nerves get stretched and that they follow down your thoracic spine. So if you've got irritation of the diaphragm by the spleen or the liver, then it's detected by C3, 4, and 5, because that's what innervates the diaphragm. But there aren't any sensory nerves in the liver. Okay, so you can't really feel this liver problem. You only feel it when it starts to encroach on other bits of your body. So the C345 receives sensory information also from your shoulder. Okay, so that same level of your neck also receives information from your shoulder. So what the body does is goes, well, it can't be your diaphragm, it must be your shoulder. And that is why you get shoulder pain with a liver problem. Okay, so when you're doing a musculoskeletal exam, you will do all the tests of the shoulder. So you do active range, passive range, active resisted. You'll poke and you'll prod it, and there'll be no pain, and they'll have full range of motion. There'll be no problem. Okay, and if that's the case, it doesn't mean that you're rubbish at musculoskeletal exams. It may be that something else is causing the symptoms, and you need to get them referred. I know of patients that I've had where this has been the case, and they've had lung cancer. Okay, and their lung cancer has irritated the nerves, either at the top of the lungs, the apex of the lung, or in the diaphragm. And then they had shoulder pain, and they had it for a very long period of time. They've been to see a lot of people, and I referred them back to their GP because I wasn't happy with their symptoms, and unfortunately they had lung cancer. So that's obviously a very extreme example. You can get pain down the arm coming from the glenohumeral joint. Okay, so remember we were talking about the joint sclerotomal pain. So there's lots of ways that you can get referred pain from the joints, from the muscles, from the tendons. A classic one is around the glute medius area, and people having sciatica, so pain going down the leg, and you push into their glute medius, and then they feel the referral down their leg. There is no nerve that goes from the glute medius down, so you're not compressing a nerve, but what you are doing is pushing into an area that's sensitive, that's the sensory nerves going into the lumbar spine, and again those nerves becoming mixed up, and then the brain thinking that it's coming from down the leg. Okay, and that is really, really common. So people will get sent for MRIs, and there's nothing wrong with their back. They'll get the report back, and they'll be really annoyed because they're going, well, what's wrong with my leg? Why am I getting these symptoms? And it's because it's not coming from the lumbar spine. It's coming from a referred pain from the muscles or the joints. Okay, so again, something else to add into the mix. Cool. I think that's a good start for sciatica. All right, things for you to think about if you've not heard them before. I hope that was useful, and I will see you next Monday, 10 o'clock, and we'll hopefully try and wrap up sciatica, referred pain, and radiculopathy and all that. Okay, cool. See you next week.